the title of the talk is Beyond 6 Feet, a guideline to limit indoor airborne transmission of COVID-19, and I'll try to emphasize a bit more about schools in particular here. So let's see. So I'd like to start with just a brief discussion of how does COVID-19 actually spread. So we've learned a lot about this in the scientific community over the last year. Roughly speaking, for any respiratory disease, there's 3 primary modes of transmission, whether it's a viral or even a bacterial disease. And that is through fomites, which are infectious residues. For example, a cough or a sneeze leaves a residue on a surface. Somebody touches that surface and then maybe touches their mouth or their eyes or their nose. And so that's essentially a contact transmission. There's also coughs and sneezes which produce large droplets, which can, fly onto somebody's face or even be breathed in. And those are drops which I'll focus on in just a moment, which actually will settle to the ground and can be seen very clearly. And then the third is what we call airborne transmission or aerosol transmission, which refers to other kinds of droplets that are emitted not only through coughs and sneezes, but through all kinds of respiratory activity, including speaking and even just breathing normally. And those are particles which do not settle very quickly, hence the term aerosol, which refers to essentially particles that remain suspended in the air for long periods of time. And those particles can go through masks and they can be inhaled by another person. And that is in fact believed today to be the primary mode of transmission among many scientists. And if you'd like to read about the background and some of the arguments, this link down here to a nice FAQ page maintained by Jose Jimenez and Don Milton and others gives some background on that. So let's focus now just on airborne transmission or droplet formation. So I mentioned that different forms of respiration do lead to droplets being emitted. So on the lower right here, we see a slow motion view of droplets being emitted just simply when you're speaking. Every time your lips touch, there's a liquid film there of saliva, which is stretched out and sort of spewed out as small droplets. And if you look in the middle here, this is a measured distribution of droplets versus size from patients undergoing different kinds of respiratory activities. And what you can see here is that the sort of around the 100 micron scale, which is a relatively large drop, we can see droplets like the ones I showed on the right that are primarily generated through speech and especially from the mouth. But that's not the most probable drop size. There are many more droplets in the range of below 10 microns or even smaller than 1 micron, which are also generated. And these droplets are those aerosol droplets I was referring to. You can't see them with the naked eye. Just for reference, a cell, a human cell or even a bacteria would be on the scale of several microns. So we're talking about droplets that are at that scale or even smaller. Now, where are those droplets produced? Well, on the far left, you can see a sketch of what's called the bronchial film burst mechanism, which is that in the deepest parts of your lungs, the airways end in sort of very small branch structures called bronchioles, and ultimately in the alveoli, where there's an exchange of oxygen and carbon dioxide with the blood. And those extremely small passages are essentially opening and closing as air rushes in and out. And they also are covered with mucus fluid. And basically, again, just like I showed you on a larger scale with the mouth, that fluid is sort of stretched out. And as the air is rushing in and out, it bursts into little fragments and it can get exhaled. So that's a mechanism for forming the smallest droplets that are on the scale of 1 micron. And another important mechanism, which has gained a lot more attention over the last year, is actually generation droplets in the larynx. So what you see on the right is a snapshot of the vocal folds when somebody is speaking. And so that's basically where sound is being made. So those white folds are flapping at about 100 hertz. And as you can see in this particular snapshot, again, there's some mucus and some liquids there that are being sort of stretched out in a fast cross flow of air and fragmented and can also be released. And in fact, it's been shown that distributions of droplets like the one I show here show a significant increase with vocalization and speech that is roughly proportional to the volume of the speech and also to the type of speech, ultimately being maximal in an activity such as singing, where there's actually quite a large number of droplets being removed, being expelled, as I will show you a little bit later in the talk. So basically, there's all these different mechanisms for forming droplets in the respiratory tract. And when someone is suffering from a respiratory infection, such as COVID-19, then there's plenty of pathogen there. So in this case, it would be capsid form of the SARS-CoV-2 virus, which are contained in that fluid and hence are carried away in these droplets of different sizes. So briefly, here is some very old ideas which still kind of have relevance today about the fate of those droplets that are expelled. So this is really traced back to the pioneering work of William Wells in the 1930s, who studied actually coughs and sneezes from tuberculosis patients, and he literally measured how far those droplets went before they settled. And he estimated about 2 meters or 6 feet. And that is one of the potential origins of the 6-foot rule that we still have today in the United States in terms of the range of droplets that one might expect from coughing or sneezing. But he also did some really nice analysis. So there are two formulas here. One is giving the settling time for droplets, which scales like 1 over the radius squared. So larger droplets settle faster. But also there's the evaporation time. And so a simple theory of evaporation of droplets would show that the time scales roughly with the area of the drop or the square of the radius. So if you take those two formulas and you plot them on the right in the form of the so-called Wells curve, you can see as a function of droplet diameter, imagine starting a droplet of a certain diameter and then following one of these vertical black lines. That is essentially advancing that droplet in time until it hits one of these two curves. So if it's a small enough droplet, it will first hit the evaporation curve, which means that droplet, according to this theory, would evaporate before settling to the ground. On the other hand, the larger droplets will hit the ground first and end up as a residue on the surface. So this kind of thinking, is based in some sound scientific principles and really has influenced how people think about respiratory disease transmission really since the 1930s. And as you can see here, it's really the millimeter scale droplets, it's the large droplets you can see with the naked eye that make it to the ground and can be measured. But Wells at that time was not able to have the equipment to observe much smaller droplets like those aerosol droplets I just showed you. And a simple theory here would suggest that those droplets would in fact evaporate. So there are still people today that would argue that actually those droplets don't exist because they must evaporate. But what's missing in this analysis, which Wells did allude to in his early work, is the fact that these droplets are not pure liquids. So the evaporation time I gave above was for a pure liquid, like so let's say pure water. But on the other hand, the liquids that are being expelled here, as I showed you, are typically mucus filled, so especially deeper in the respiratory tract, but also even from your mouth, saliva. And these respiratory fluids have significant volume fraction of solutes, which are charged macromolecules such as mucin proteins and various salts, which do not evaporate. And in fact, as those droplets shrink, those solids are still present and basically help to stabilize the size of the droplet. And so that the ultimate size you get depends on relative humidity, and basically a formula is given here. And so a more realistic picture of what these droplets look like is sort of sketched here, where the virus or the virion, the capsid form, which for COVID-19 is about 120 nanometers in diameter, is like one of these little red dots. But there's also lots of other molecules present and even solidified salts and everything in these what we might call droplet nuclei. So these are partially evaporated droplets, which then are the ones that are being measured. So in fact, this measurement I show here are droplets that remain stable. So they do not evaporate, and they are simply swept away in the air currents. They may eventually settle, or they may be breathed in by somebody else, but they don't just disappear, and they are containing the pathogen. Okay, so that's just a bit of the sort of physical background. Now, I don't have time to go into all the details here. There are many scientists that are convinced, and I'm one of them, that airborne transmission is the dominant mode of transmission for COVID-19, and in particular, that that transmission is primarily occurring in indoor spaces. And that's simply because in indoor spaces, the air is more contained. It's easier for people to exchange that air by breathing, as opposed to outdoor spaces where it, basically quickly gets whisked away and diluted in a very large space. There's a lot of evidence we can point to. I don't have time to go through everything, but if you look at some of the pictures here and some of the discussion highlighted on the left, there's some famous cases which I will use in my analysis or refer to anyway. such as a case in China where there was a spreading event in a bus where one person infected about a third of the people on the bus, and there was no correlation with seating on that bus. It appeared to be airborne transmission. Interestingly, that case, there was sort of a control bus because there were two buses going to this particular religious ceremony where these people were heading. And then they came back on the same bus and no one got sick on the other bus. There are also other cases such as the Diamond Princess and other cruise ships that I'm sure you've heard about early in the pandemic. The Diamond Princess had a 12-day quarantine starting with a small number of cases, we don't know the exact number, and finishing after 12 days with 354 cases on board out of about 4,000 people, despite the fact that everybody was confined to their rooms other than the crew. And yet it spread to different floors, different places, so throughout the ship. Another important case, which we will analyze shortly, is a choir practice at the Skagit Valley Chorale in Washington State. This was one of the first outbreaks in the United States, and to this day is still one of the most notorious spreading clusters because one person infected 86% of the group of 61, and 2 people actually died. But yet, in a 2.5-hour choir practice, there was no no real close contacts in the usual sense of 6 feet for 15 minutes, that sort of thing. Now, also, there have been statistical studies of transmission, for example, that all the first cases outside of Wuhan and Hubei province in China, the vast majority, in fact, essentially all 318 outbreaks of more than 2 transmissions occurred indoors, and the vast majority in family apartments, and the next largest situation was in public transportation. Only 1 cluster was recorded outdoor, and that was only 2 transmissions. And then finally, infectious aerosols have been directly verified in several studies, where in one case, the study of Lednitsky, samples were collected in a hotel room with, hospital room with COVID patients. And even 16 feet away from the patients on the other side of the room, they collected droplets from the air and even were able to sort them by size and demonstrate that they not only contained the virions, as shown in this picture in the middle here, but were also that they were infectious. The virions could still shed and reproduce their RNA. So that's just a quick overview. Now, I'm not the first person by any means to be arguing for airborne transmission. Many serious scientists have been doing so since the very beginning. So I mentioned here 2 sort of warning papers that were written by Lydia Moravska. For example, Airborne Transmission, The World Should Face Reality, back in April. Also Bill Rissenpart is another chemical engineer who basically was saying the same thing. By the summer, Moravska and Donald Milton, who I mentioned earlier, and actually many others, essentially signed an open letter stating that they believe the coronavirus is airborne and laying out the evidence for that. This was reported in the New York Times and elsewhere. I would have gladly signed that letter, but I wasn't involved in that group at that time. But I think there's quite a big consensus on that topic. The CDC, though, did not acknowledge airborne transmission until September, but then actually it posted some guidance and then took it down. And then it came back. And so by October, there was an official statement that airborne transmission is possible, although was suspected not to be dominant. And still the guidelines haven't really changed. We're still, the official guidance is disinfect surfaces and stand 6 feet apart. On the other hand, the medical community was taking notice of all this. And for example, here's an editorial from The Lancet in October saying public health guidance now needs to advise people how to navigate risk in indoor settings. So that's exactly what I've been working on and what I'd like to tell you a bit about today. So first, let's think about a little bit the existing rules. So I would characterize them as fairly arbitrary single variable bounds. So the one we've been discussing is the distancing guideline, social distance of 6 feet. I will show you further evidence later why that 6 feet is not a particularly clear number from a physics point of view. But you might also notice that outside the United States, people typically are enforcing shorter distances. For example, the World Health Organization recommends 1 meter, which is closer to 3 feet. Now, that's a very big difference. Those of you working with schools know that if you can be 3 feet apart instead of 6 feet apart, you can return a classroom to normal occupancy. But if it's 6 feet apart, you're roughly cutting the classroom occupancy in half, and hence you must go to hybrid or remote learning. There's also been together with this recognition of indoor airborne transmission. We started to see in the fall, like around Thanksgiving, various states and governors imposing limits on indoor gatherings. So for example, Thanksgiving gatherings could be limited to 6, 10, or 25 persons, depending on where you lived. There were also caps on gathering sizes in general. Also, there was a growing appreciation of ventilation, especially in other countries. So in the United Kingdom and also in Germany, various rules have been suggested to maintain certain ventilation rates or to open windows after certain periods of time in order to worry about and limit airborne transmission. Another very important variable we're going to come back to is time. Time does arise in the CDC's definition of a close contact for contact tracing, which is 15 minutes of contact or more with someone at less than 6 foot distance. But you might ask, how does time connect to, other situations? Because as I highlight here in blue, it's common sense that if you bound one quantity, let's say the occupancy of a room or the distance between people, that there's always a transition from unsafe or unnecessary to unsafe. So take distance. If I stand 6 feet apart from some people in a room, and I do so for only a few seconds, there's essentially no chance there'll be a transmission. So it's kind of an unnecessary rule. But if I stay in that room for a longer time, and I actually understand what's going on with the air currents and everything else, eventually it is unsafe. And so I have that sort of transition. And this coupling in between variables, I first noticed it in California's Thanksgiving rule, which because they said no more than 3 households for no more than 2 hours. So they were at least acknowledging that somehow occupancy and time must be linked. But is that always true? Like, can I apply 3 and 2 to like a school or to a business? Or, how would I decide that? Or what if I change ventilation? Or for that matter, what if we're wearing masks versus not wearing masks? Should I still have 3 households in 2 hours, or can I change that? So the basic idea is that all these variables are clearly linked, and we need some more quantitative guidance to make any kind of policy decisions, including for schools, which is our main focus today. Beyond, as you see in this picture, people simply measuring distances between chairs. Okay, so that then brings us to my attempt with also my co-author, John Bush, to develop an indoor safety guideline. And by that, I mean a relatively simple formula that we think contains all the key variables, and which we've done our best to parameterize with the latest information for COVID-19 and then make that available to the general public in the form of a calculator, which I'll show you in a minute. So just a very brief summary of the model and the equations. The details shouldn't concern you too much, but from my perspective as a chemical engineer, the model is that of a continuous stirred tank reactor where we have a room and there's an infectious substance which is well mixed in that room, and then there are people in that room that can sort of sample that infectious material. In the field of epidemiology, this general type of approach is called the Wells-Riley model. And again, the details are not critical for today, but I just want to indicate the kind of variables that come in. So there's generally a production rate of infectious air, which is essentially has to do with the droplet distributions and the type of respiration someone is performing who's infected, and also whether they're wearing a mask and what's the filtration effect of that mask and their breathing rate. There's also a removal rate of virions from the air, and that happens by ventilation, sedimentation of particles to surfaces, filtration, if we do have any filtration occurring where the air is being passed through some sort of filter, and also just deactivation of the virus. So either naturally or through enhancements due to, say, plasma or UV, the virus essentially becomes inactive or deactivated with some rate. And when you put that all together, you can define or derive basically a transmission rate, this beta of T, which depends on the size of droplets R. So it's an integral over all the droplet sizes. And then that allows you ultimately to get the kind of formula that I've been advocating for. Now, I'd mention here, there are other scientists who've created similar models. And in fact, this Wells-Riley type of modeling is not by any means invented by me, but in fact goes back to the same William Wells I mentioned earlier from at least the 1950s, and Riley, who applied his model to measles in the 1970s. So it's a very well-established modeling principles in the field of airborne disease transmission. But what I've tried to do here is to analyze those models as carefully as we can, given the available data, taking into account droplet size distributions, and then provide sort of a mathematical simplification of those models in the form of a guideline formula that really tries to show you how the different variables are linked. And so first, let me briefly summarize kind of how the analysis goes to kind of parameterize and validate the model. So first of all, I took distributions of respiratory droplets taken from a study of Moravska in 2009. They were measured for different types of activities, such as singing, speaking, whispering, breathing through the nose, breathing through the mouth. And then using the model I just showed you, I say, let's imagine that each of those activities were going on involving the people in, say, the Skagit Valley Corral situation, where we have recorded, it was known what is the size of the room, their estimates of the ventilation rate available. So all the parameters that I need are essentially there. And what you see here is that the blue curve is an estimate of the droplet distributions, the aerosol volume fraction in the room as a function of droplet radius for singing, which is actually what they were doing. If they were not singing and they were performing these other activities like speaking or whispering or breathing through their nose, you would have much smaller amounts of droplets, and we can also see what those would look like in that room. So basically, by fitting the observed rate of spreading in that room for singing, I can then use these distributions to rescale for what would be the rate of infection spreading if there were other respiratory activities occurring. So that's one piece of information. And we've also looked at other cases, like I mentioned that Ningbo bus, also the Diamond Princess cruise ship is shown here. So we can also fit kind of the rate of spreading there and extract a consistent number for the infectiousness of the air in that situation as well. Although that's obviously much more complicated because it's a big ship. We don't know all the details of how air was exchanged on that ship, but still we can make some estimate of the rate of spreading, which turns out to be consistent. And the bottom line of all that analysis is shown in this plot is to get what in the model is a single disease parameter, the infectiousness of exhaled air. And it depends on the respiratory activity or the expiratory activity, meaning you're exhaling air. And that's what we're trying to understand the infectiousness of that. So I've broken it here into sort of breathing, speaking, and singing. And the infectiousness of the air is measured in a certain way on the horizontal axis here. And another thing that's done here is also comparing two different studies of droplet distribution. So the blue is the study of Moravska that I mentioned earlier. Bill Ristenpart's group also recently measured droplet distributions for different activities. And so the way this works is we basically fit the Skagit Valley Corral for singing using Moravska's data, and then we rescale that for all the other respiratory activities. And then to bring in Ristenpart's data, we calibrate and say, okay, for intermediate level speech, we say that it lines up. And then the orange curves tell us what those other studies would predict for different kinds of activities like loud speech or quiet speech or different types of breathing. So you can see there's some fairly consistent trends here in sort of how infectious the air is as a function of the respiratory activity. And also I indicate here where the bus and the Diamond Princess would fall, and you can see that you're getting somewhat consistent values that are in the estimates that would correspond to basically, for example, speaking or normal breathing. I can also mention that another output of this study is an estimate of the so-called infectious dose for COVID-19, which is still not consensus in the scientific literature. To make that connection, you need to take the numbers I've shown here and have some idea of how many virions there actually are. So since we do have an estimate through this analysis of the volume of infectious aerosols, if we assume that based on literature measurements of the viral load, that the cases we've looked at, which are super spreading events, correspond to the highest viral load that is typically measured for people at their peak moment of infectiousness, and we only look at the aerosolized virions that are in those droplets that are at the 1 micron scale, then we get an infectious dose of only 10 virions, or an effectivity of 10%. Previous analysis of airborne transmission of the original SARS coronavirus, which, by the way, scientists believed and accepted to be transmitted by the same airborne route, it's about 10 times more infectious. And that makes sense because the original SARS did not cause a pandemic, whereas the new one did. Now, this is not to say that every single virion has a 10% chance of causing infection, because many of them are contained in large droplets, even in feces or other places, that are not going to cause infection. We're asking only for those aerosolized virions that actually get breathed in and get to the deepest parts of your lungs, for example. This is an estimate of how infectious they are. But for the analysis we're doing here, we don't really need to know that infectious dose exactly, because we don't really need to know exactly how much is the viral load, for example. What we really need is this infectiousness measure of the air in so-called units of infection quanta, which is what something Wells introduced that's very convenient here. Anyway, so now we come to the safety guideline, and this is really getting to the important part of the talk here. So basically, if you take that theory and you kind of flip it around and you say, my criterion, the simplest, most general criterion for, quote, safety or controlling transmission is to put a bound on what I call the indoor reproductive number. What that means is if I know the number of susceptible people, S0, so that would be everyone in the room, or if there's been some vaccination or immunity, it's something maybe less than that, times the average transmission rate beta times the time that the infected person spends in the room. What that number is, it's the expected number of transmissions, which is also an upper bound on the probability of a transmission. So this epsilon here is sort of a risk tolerance, which is to say that to impose a guideline, I'm going to say I would like the indoor reproductive number to be less than some value, for example, 10%. Or if it's a really high risk population, let's say elderly in a nursing home, I might drop that to 1%. I really don't want a transmission to happen. So there's a notion of your risk tolerance. And once you have that, you can then convert that into a bound on all the other variables. And in particular, you get this boxed formula here, which is expressed as a bound on what I call the cumulative exposure time, which is the time that an infected person might spend in that room with the other people. And n-1 here is the number of susceptible people. And that's assuming that all the other people in the room are susceptible, which is kind of the most conservative estimate. And then how does that bound depend on other properties is shown really by the equation, the right-hand side of the equation that's boxed. So if you look at the plot down below, if you look at occupancy versus time, this bound of n-1 times tau less than a constant is basically the light blue curve. It's kind of a hyperbola that has this sort of shape here. And what it says is for a given set of parameters, if we pick a certain occupancy, for example, let's say the occupancy that's set by 6-foot distancing in a particular space, or maybe some other measure, then initially that's very safe. As I indicated, if we're only together for a minute, everything's fine. But there's a certain point where you cross the blue line and then suddenly it becomes not necessarily immediately unsafe, but at least there's a risk of transmission that is getting larger than your tolerance. So if you set the tolerance to 10%, there's a 10% chance you might actually see a transmission in that case, which we don't want. And then you might say, well, how do I, engineer or design the space to be safer? Well, what I want to do is increase this bound on the exposure time. I want to basically move it up along the blue arrow up and to the right. And the formula tells you how to do that. So the things in the numerator of that formula you want to be larger. So you'd like to have a larger room volume because that dilutes the air. You'd like a larger ventilation rate. So that's the rate at which the air is changed with outside air. And that's happening, by the way, even if you don't have the air conditioning on and you have closed windows, there's always some leakage of air, which is necessary just for people to be able to breathe. We can't place people in indoor spaces that don't have an outdoor air exchange, or you wouldn't be able to survive. So there's always an exchange. And even when the windows are closed, that exchange might be on the order of hours. And of course, if fans are on or ventilation is running, mechanical ventilation, it could be on the order of 10 minutes, let's say. There's also potential of filtration, so we can filter the air, and PF is the filtration efficiency, so we can pick different levels of filtration. There's also the viral deactivation, which you can enhance in various ways. And then the denominator of this formula, you want to be small. So for example, we would like to have a small breathing rate. So if we breathe faster, it comes in squared, by the way. So if you go from like resting to heavy exercise, there can be a factor of 5 or so there. And so if you square that, that might be a factor of 25. So that's a pretty significant effect. The infectiousness of the air, I already talked about, that's the CQ, which sort of varies from singing down to nose breathing by actually quite a bit, by a total of almost 3 orders of magnitude. And then there's the mask factor. So while we can debate exactly how well certain kinds of masks and the way that they're worn and they fit can provide filtration, still that factor comes in squared. So even fairly poor filtration, which we maybe 30% of the aerosols get through, you still square that, and that ends up being a factor of 10. And then finally, there's also the relative susceptibility. So there is enough data, I think, now to quantify the extent to which children versus adults and elderly have different levels of transmission. And roughly between children and elderly, I think we can estimate it's about a factor of 4. So children are about 4 times less likely to transmit, not to get sick and die, but to simply to transmit than some of the worst cases of elderly. There's also the new strain we've all been hearing about. And in fact, there's several new strains. The one that we've heard the most about is from the UK. And the estimate there, that's the first strain for which I think we have some decent data to estimate, is maybe about 60% greater rate of spreading than the original Wuhan strain. So we can account for that too. And the bottom line then is that this formula tells you kind of how important each of these factors is. You can essentially put them in order. So the number one thing is wearing masks, because that can be even up to a factor of 100 improvement in your time or your occupancy. But increasing ventilation certainly helps. You can get oftentimes a factor of 10 there. Certainly reducing your exertion and avoiding sort of singing and loud speech can also reduce your droplet emissions significantly. Filtration is helpful, although not as helpful as you might think. The reason being that you can't filter all the air, because as I said, fresh air always has to be passing through the room. So filtration works by recirculating the air through a filter, and you can't recirculate everything. And so if you have an outdoor air fraction that say is 20% and the rest is recirculated, then the best you can do with filtration is maybe a factor of 5. So that's good, but it's not as good as some of these other factors. And then finally, humidity and other parameters also have a smaller effect. So that's the guideline. And I have basically put out a spreadsheet and also an online app to help people implement the guideline. And the app is actually translated into many languages too. And if there's a little time at the end, we can take a look at that. Here are 2 case studies using that formula, just kind of to get a sense of what can be predicted. So on the left is a classroom, on the right is a nursing home. So for the classroom, we assume a moderate to low risk population. So we'll set the risk tolerance at 10%. And we assume that they're not even wearing very good masks. So let's say 30% of aerosols are not filtered. So we're not really, we're being, I think, conservative in how much mask can help. And what you see is this boundary between sort of safe and then increased probability of transmission. And you can see, for example, how it depends on ventilation. So the blue curve would be natural ventilation, where we have no forced air and closed windows, and that might be an air change of every 3 hours. And the red curve would be pretty good mechanical ventilation, and you can see how that moves the curve over. And what that does, it buys you either better occupancy for a given time, or it gives you a longer time at a given occupancy. And you can see also the bottom axis is the time without masks, and the top axis is the time with masks, and that's a cumulative time in that space. So notice with the masks, we're talking about a time on the order of days, and that again is a cumulative time. So for example, if you have an occupancy of 20 in this room and you have good ventilation, you might go 3 days or 72 hours of cumulative time. And in terms of actual real time, since you may only spend 6 to 8 hours a day in the room together, that's more than a week of time. And if you're either testing or simply allow for the recovery from the virus, which is also on the order of 5 to 10 days, that's a pretty safe situation. On the other hand, if you didn't have the good ventilation, you would be at a much lower time, and then you would conclude that might not be safe for preventing transmission. But basically what this is showing, if you do many calculations like this for sort of typical classrooms in particular, you would conclude that when masks are worn, and people are in reasonably well ventilated spaces especially, that transmissions would be rare. And in fact, there is growing data that supports this. They say that school transmissions are relatively rare compared to, for example, transmissions in people's houses where they're in small spaces without masks. and also that in fact students can be safer at school or on campus than off campus. There's plenty of data to support that at universities, where essentially if you have the students in the classroom with their masks on, kind of more regulated, there really aren't very many transmissions. On the other hand, when you let them off campus and they're meeting for parties, and doing their own thing, then actually that can be worse. Now, on the right, we see kind of the opposite extreme of a nursing home, where we have a high-risk population, which has also the highest level of transmission possible. And you can see here that, and also we're assuming a smaller space, like in fact, we're using a typical size for a nursing home room in New York City, actually, which would have a maximum occupancy of 3. And as we all know, especially early in the pandemic, COVID patients were housed with others in nursing homes in relatively small spaces. And we all know what happened there. There was a very significant transmission. And in fact, the guideline also is consistent with that. It tells you that you could have transmission really in as short as 15 minutes, at least with this level of risk. So it doesn't mean it will definitely happen in 15 minutes, but you start to have some significant risk. Here I put that risk at 1%. So actually you would actually expect a transmission to occur maybe after many hours, let's say. But certainly if people are sharing that room without wearing masks, and frankly, even if wearing masks, there is a significant risk of transmission. So this is consistent with the observation that 1/3 of global COVID-19 deaths have occurred in nursing homes and elder care facilities. So what I want to show you now is, actually it seems to be still loading. Yeah, okay, so, oh, there we go. Okay, so here's some movies from, sorry, let me pause this one. This is from Paul Linden's group at University of Cambridge, from the cited paper here. And so here you see some visualization of the airflows around people. I just want to indicate to you that when you're not thinking of coughing and sneezing, there's not a big ejection of fluid. Like you can see these respiratory plumes that extend, maybe a foot or two, but notice the warmth of the air from your body and also the exhaled air tends to rise. Even when you're not breathing, just the warmth of your body itself in contact with the air makes the air rise. So kind of like around a candle, the air is typically rising. And if you look at the middle, you can see this is somebody speaking who would be emitting more droplets and more plumes of air, but notice the mask not only filters, but it also blocks the momentum of the air. So you can see the air leaking out around the nose, but again, it just essentially rises. So kind of like sketched on the right here, a person breathing actually is a bit like a chimney. And this can be seen more clearly in the simulations here by Mike Kinzel at University of Central Florida, who's I'm actually collaborating with now to help assess indoor spaces. And in fact, this is a simulation of a classroom. And you can see each person is emitting droplets and breathing, and then the air currents are being simulated, including ventilation effects. And there's one infected person who's sitting and sort of puffing away, in the second row. And what you can see is that, if you were to sort of get right into one of those puffs, you would have an elevated risk of transmission, but those puffs tend to rise, so they don't really extend too much laterally, and certainly 6 feet is not a particularly relevant number, and they become well mixed. And so the real risk to everyone else in the room is actually breathing that background air. And that's shown here on the right. If you take those simulations and you sample at different locations, for example, the positions of the other people in the room, what you find is almost no correlation with distance. So the well-mixed model is actually a pretty good approximation. And in particular, there's really not much difference between 6 feet and 1 meter, which is more like 3 feet. And again, coming back to school regulations, given the huge difference between imposing 6 feet versus 3 feet, I think, the simulations, the data for transmission, and in my calculation also, all support the idea that we could reduce that distance or not impose a strict distance of 6 feet anymore for indoor spaces, especially when masks are worn. And that brings me then to kind of a way to think about indoor transmission, which is just to think about smoking. So the same point is made by other scientists, including this FAQ link that I gave earlier, where this picture came from. So there's the short range transmission through respiratory plumes, and then there's the long range transmission that comes from just the background air. And it turns out that, especially when masks are worn and this short range transmission is sort of cut off, that the primary risk is in fact the long range transmission, which is fairly well described by the guideline that I gave. And I'll jump ahead that I guess we're running out of time, almost finished here. So We can analyze those respiratory plumes and get a formula for sort of the elevated risk if you happen to be in one of those plumes. I won't go into the details there. That's actually from the work of Howard Stone at Princeton, and it's something that I've integrated into the analysis. But I wanted to get to this picture, which is just one example, but it shows the kind of thing we can predict with the guideline, which is really, to me, the right way generically to formulate a science-based policy for reopening and closing spaces, instead of just picking arbitrary numbers and kind of imposing those, but really basing it on the science. So what I've shown you here is imagine we have like a school classroom that has an occupancy of 25 normally. And let's just say that the safety guideline that I described, given the ventilation and other factors, would give you a number like 11, okay? Now the safety guideline is predicated on the assumption that there is one infected person. Okay, and also that all the other people are susceptible, right? Now that's like a worst case scenario. And of course, we would want to impose that when we're trying to limit the spread of the disease. In fact, if everybody did that, if every space were so protected so that every one person doesn't have a good chance of infecting anybody else, the epidemic would disappear because there wouldn't be this sort of accelerated spreading. However, as you go to the left on this plot, you reduce either PI, the probability someone is infected, based on the prevalence in the local population, and also the probability somebody is susceptible. So as immunity goes up due to previous exposures or vaccination, then the number of people that actually are susceptible is also going down. And it turns out that it's actually the product of those two numbers that matters. And basically, as you go to the left, so the community is recovering from the pandemic, then there's sort of several stages. First, you can increase the occupancy to full occupancy, and we have a formula for that, but you're still wearing masks. And during that time, as I showed you, you don't really worry about distancing. But then you keep moving to the right along the blue curve, and then you cross a boundary where you could actually take the mask off, but then you start to worry about distancing a bit, because I've mentioned these respiratory plumes. And so if you maintain 6-foot distancing, that's already at a pretty good distance for protection from typical breathing. Then you have a certain crossover, and then you eventually can go down to, let's say, 3-foot distancing, where essentially I would say at that point you're back to like normal. You have full occupancy, no masks, and you're not really limiting people's distance, because most people don't like to stand within somebody's space bubble of less than 3 feet anyway. Now you might say, where are we on this plot right now? So Massachusetts, the active case rate now is about 0.2%. And the other values in the United States, in some of the worst places, are kind of in that range, which is shown in the red. So what's interesting here is that that's well in the range of full occupancy with masks. So I would say anywhere in the United States right now, it would be fine actually to have schools completely open, but I would recommend that people wear masks. I also would say that we shouldn't worry about distancing. And then if we, as the prevalence of infection goes down, it's maybe another factor of 10 or so in that number, then we can really start talking about eventually getting rid of the masks and even getting rid of distancing. And that's another sort of discussion we can have. But I think this is an important message. And of course, if another third wave comes back, then we move back to the right. We put the mask back on, we lower the occupancy, but we do it according to a science-based formula. And these curves on this plot do get moved around by ventilation and other effects like that. So if you want to manipulate this curve, I've shown how that can be done. So basically, I'm just now finishing up, and I just want to point out that we understand airborne transmission in the case of secondhand smoke. So I've taken these graphics from the CDC's website talking about secondhand smoke. And they say, look, just because you're on the other side of a restaurant doesn't mean that the smoke isn't coming to get you. So they've got this sort of skeletal smoke, and I've just put the word COVID-19 there because that's essentially how you should think about it. In fact, they even point out that secondhand smoke can go through buildings into different rooms and pose risk. And in fact, that has been shown even for COVID-19. A recent case of a Korean apartment building, there was a pattern of transmission in the building that perfectly followed the ventilation ducts between rooms and apartments where people had had no other contact with each other. So with that, I'll just conclude and just refer you, as I think you already have the link, to my online app and spreadsheet that helped to implement the guideline, and also to my online course. So if you'd like to learn more about some of the principles I've shown you, there's a free self-paced course on edX, which you're welcome to check out. So anyway, I'm sorry that I started so late and didn't have a chance to leave you enough time for questions, but I'll wrap up here, and I'm happy to stick around if we have time for questions. I'm sorry, Susan, for my screw up with the technology today.
Oh, no, that's great. Thank you. There are a couple of questions that I'll just put out that for you to respond to, and then we can see if people want to stick around for just a little bit. And if not, we can certainly ask that you come back and talk with us a little bit more about the app, because I think that's a very, that could take us for a long time.
Yeah, I know exactly.
As well,
I can pull
right?
it up. I was hoping to like play with it in front of you and answer
Right.
questions like as we're looking at it, but you know.
So, well, if you want
to,
if you'd like to pull it up, that's fine. And I'll
Sure.
just ask some of the questions in the chat box while you bring that up. Mary Filardo was asking if the model assumes that there is no foamine or droplet transmission in your model.
Fomite.
Yes.
Sorry, I'm sorry.
Fomite transmission is not committed or not considered. One reason is I wouldn't really know how to consider it, in the sense that, you know, I guess what principles would you use to predict exactly how that would work? To my knowledge, there's not a single documented case of fomite transmission of COVID-19. It's not to say it can't happen. It certainly could happen. But, you know, there are many, many, many documented cases of airborne transmission. And I think also the analysis that I and many other people have done, you know, are kind of consistent in estimating and interpreting the rate of spreading for indoor cases that have been looked at. But yes, there could be fomite transmission, which is not considered here.
And what ventilation rates are you assuming for the guideline in that case chart?
So just the school example I gave,
yes.
Well, there was a range. So
okay.
On the one hand was basically closed windows with no forced air or anything. And that was a ventilation, an air change rate of 3 hours, which is kind of typical for, you know, when the windows are closed and you're not doing any attempt at ventilation. As soon as you open the windows or turn on, you know, fans, bringing in any outside air or any central air system, it goes much higher than that. And so the other curve was kind of on the higher end of what would be typical for a school, which would be 8 air changes per hour. That's pretty high. It might be more like 2 or 3 is a more typical number. But still, that means, let's say it's 3, that's air change every 20 minutes, which is a lot better than every 3 hours, you know, so there's kind of that range there.
Right. And we talked about this following question, as you and I and Chris talked about this morning, which was, you know, how does fecal aerosol transmission play into the roles in the studies that you're citing, and how is that considered?
Fecal. So we know that you know, the virus or the virions, the capsid form, can be found in fecal matter, and in fact, you can get a sense of sort of the scale of infection in a population by looking at the sewage. That's certainly true. However, the virus in the fecal matter is typically not as infectious, and I don't know of any demonstrated cases of transmission that matter. You might also wonder how respiratory virus is going to get from the sewer or the toilet, you know, ultimately into your respiratory tract. It's not to say it can't happen, but that seems a lot less likely to me than, you know, direct exchange of these droplets that are, you know, basically constantly being emitted by an infectious person and breathed in by someone else. Yeah.
Okay.
So it's one of these things that's possible, but it's probably not nearly as likely as what I've been showing you here.
Right. And then one of the questions related to distancing is distancing useful if only to reduce the number of people susceptible to the infection in a given space?
Yes, absolutely. So occupancy is definitely important. And that's because, you know, we're trying to limit the probability of any transmission. So the more people in the room, the more chance there's a transmission, right? So it's roughly proportional to that. So distancing does have the indirect impact of just reducing the number of people in the room, and that can be helpful. But again, to make a policy decision, let's say for schools, we go to half occupancy, right? You really have to explain why that factor of 2 is so important. Like if you're right at the edge of safety, then a factor of 2 might really save you. But if, as I indicated in my last plot there, if you're pretty far from that boundary and the situation is fairly safe, then that factor 2 is useless. It doesn't make a difference really compared to the other factors that are, you know, that could also be varied, like ventilation, et cetera. So it really kind of boils down to the numbers, you know, whether that's useful or not. I also indicated that as you saw in those airflows, when people are wearing masks, especially, there's really not much lateral motion of the air and of the droplets that are emitted.
Right.
In fact, they tend to rise and then eventually get carried away in air currents, just like secondhand smoke. When a smoker is holding a cigarette, it rises up and eventually it's everywhere in the room. But if people are not wearing masks and they're facing each other, for example, in a restaurant or in a meeting, where you're like talking at each other at a short distance, then there definitely is an elevated risk there. We can quantify that using the sort of fluid mechanics of those respiratory plumes that I mentioned. And then distancing does help, certainly. But on the other hand, it still may not be that necessary. I mean, keep in mind that people don't usually put their faces right up against each other. There's usually a few feet, before the next person, and there's still dilution. There's still airflow that carries everything away. So basically, when masks come off, distancing becomes relevant again. But it's not. But still, it may not be necessary. Again, it depends on the numbers, and that's what we've tried to do here.
And the type of masks that you're using in the model, is it the high level, industrial and what's being used in the healthcare industry, or is it just me putting my cloth mask across my face?
Right. So you can do whatever you want with the app, which we're looking at right now. But the case study I showed you is just one example. I'm not telling you every case will be exactly like that. But that was for the case of the classroom. I intentionally chose only 30% of droplets get through and aerosol at the aerosol scale, meaning there's 70% filtration efficiency, which is pretty conservative. That would be something like a not particularly good cloth mask that for example, children might be wearing. It also could allow for some poor fit also, because if you wear like let's say even the blue surgical masks, which have the material itself has a much higher filtration efficiency, but if you don't have it really bent around your nose, as you saw in the video, like the fluid is basically just like pumping out past your eyes, and so the fit of the mask is also important. But indeed, that example I think doesn't you'd be careful not to overestimate the benefit of masks, but we tried there not to do that. Although certainly you can put in better masks. So for example, here's how the app looks. Like if you look under human behavior, you can specify. So you can pick like the type of mask, let's say cotton or surgical, and then you can slide also a compliance or fit factor. So you can say, well, people are really mostly not wearing it very well, so we'll drop that to 50%. And when you do that, it recalculates, all the numbers basically. Although right now I seem to be having an internet issue. Yeah, so there's sort of like what the app would tell you. So basically different number of people for different amounts of time before you would start to have elevated risk. And of course you can also now switch. We are just rolling out very soon, like switching the strain to the UK strain. You can see the numbers change, and you can go and specify your room size and lots of other things. So I won't spend a lot of time on the app, but
so the variant or the viral strain that you're using for the COVID-2 versus the UK versus the other one, your model actually does take into consideration the different level of how infectious it may be?
Yes. I mean, to the extent that that's known. So you have to keep in mind the value we're using, which is about 60% greater risk of infection, is basically inferred from the rate of spreading in England in the early days and from the only publication that has analyzed that.
Right.
Although I would note that that publication came from the same group that predicted 2 million deaths in the United States by April. So with very similar models. So I'm not saying the model's wrong, but it's just to show that we don't necessarily know exactly these numbers, but what is clear, it's more infectious, and we have accounted for that as best we can. I know there are other strains too, and we're watching the literature closely, but I don't think we can even quantify what their properties are yet. So there's like the South African strain, the Brazilian strain, and that have been identified as potentially more infectious. But the nice thing about an online app is that you don't have to download this software again. Like we'll just change it. So as soon as we feel that we can put another strain here, we will, and you'll see it. And by the way, what we're looking at here is the laptop version, but if you visit this with your phone, it looks kind of like more like an app. In fact, what happens, it's almost like kind of squeezing this here. It starts to look more like, kind of like a phone, but it's actually adapted for mobile usage.
So is your team, I know we talked with David before about this work and how to kind of have influence with the Biden administration and CDC. Are you all talking as well with CDC about these studies, or how can we be helpful in that space too? How can we be advocates for, as you know, the science?
Yes, so as I said, there are other scientists who are trying to, I think, make very similar points. I have had some contact with public health agencies, including World Health Organization as well, but not to the point where, you know, maybe change has happened yet. But these are very conservative organizations, as you know,
Right.
and so, you know, they just move a little bit, you know, more slowly in terms of changing the guidance. But you know, I would appreciate any help in reaching the right people. I was really encouraged with the messaging from the Biden administration, even recently from the CDC, with regard to reopening schools in particular. I've myself been actually advocating for that for a long time. Again, based on the guidelines shown here, not to say that every school should reopen, but just if the guideline here is followed, that I feel pretty comfortable that we could be open. And given the great value to children and their parents to actually have school operating, I think that the risk is tolerable, and you know, or at least can be made tolerable when you look at this analysis. So I'm encouraged to see that that seems to be, you know, a trend that we're open to now.
Right.
But yeah, I would be happy to speak. I've also been in touch with a whole variety of industries in terms of just making arguments internally to sort of make their own spaces more safe or assess their safety for spreading, but also to use the information here to advocate for change, for example, by lobbying, you know, with the public health agency in a certain state, like, could we please allow, you know, this type of business to open? There's a few examples of that already using this analysis. But certainly the big change needs to start at the top.
Right.
And if you know, as long as the CDC is saying 6 feet and wash surfaces, and it's not really emphasizing airborne, it's going to be hard to really get anything more than what we currently have.
Right.
So.
Right. Wonderful. Well, thank you very, very much, Martin, for your time and for all of the great detail and, you know, walking us through all of that. I think all of us are struggling with how it has evolved since back in March and where we are today. And, you know, I know out here, we're still disinfecting our schools
Yes.
over 24 hours, as opposed to we just, you know, we had 2 people in a high school and we're still closing our schools. So
Yeah,
this has been
and
very,
I'm not
very
advocating
helpful.
that like it's not helpful to disinfect. Obviously,
Right.
that can't hurt. But the question is, you know, it's the relative importance of these different types of interventions, right?
Right.
They all cost time, money,
Yeah.
effort, you know, and also if you're focusing on the wrong thing, it can be distracting. I come back to the secondhand smoke. If I told you that washing surfaces is good for preventing you know, sort of respiratory disease, you know, from smoking, like, you know, lung cancer, well, you know, there might be some benefit, but probably not that much. And if you focus on that, then you might forget, oh, I'm standing next to a smoker for the last 15 hours
Right.
and I'm getting sick because I'm
Right.
sitting here wiping down the surfaces. So it's a question
Right.
of where you're just simply just knowing what to think about.
Right.
I think it would honestly save a ton of lives, and it would slow down transmission a lot if people were just thinking along these lines. But unfortunately, people are distracted to be thinking only about distance and washing surfaces. Again, it's not that those aren't potentially valuable. I just think what I've told you today is much more valuable in limiting transmission. And you know, that message is kind of getting out. That's why we're all wearing masks. That's why
Right.
people are talking about ventilation. But it hasn't really sunk in as sort of like this is the number one thing we should be thinking about, and that there are quantitative ways to do so. That's really what has not somehow reached a wide audience yet, I guess.
So when will your and then we'll close off. When will your app be updated for?
So the app, so this is, by the way, the new version. The old version is here, which has all these nice languages. Actually, here it is in Hindi, actually, and in French, whatever. So the old one is sitting there right now.
Okay.
And the new one probably just within a day or two, actually, although the translation of the new one will be a little bit slower because there's some changes there. You know, we could spend more time on it. I don't want to take too much more of your time, but if where we've really made the big changes in advanced mode, where now you can specify the strain and the age group as before, but now we can start saying, well, what if actually there's some immunity? So let's say the vaccine's been starting to work, people have had the disease, and let's say we're up to 30% immunity in the population, then you start to see how the numbers change. Again, and then also, what about the prevalence of infection here? So if we know that there's only 100 people per 100,000 that actually have active cases in our location, then that also, has a big effect actually. And so you could say, well, as we recover from the pandemic and this number keeps going down, then you can see how your safety changes. Or if, let's say, there's a second wave and we come back to like a really high level, again, the numbers start to change. So.
And Martin, real quickly with the masks in your age group, you're able to control the ages in the classroom. Is that correct? So that you'd be able to
yes.
figure out whether, the impact of masks with little children as opposed to adults. I mean, we all face the challenge of, I don't want my 5-year-old to be wearing a mask, but my 18-year-old perhaps should be wearing a mask, those kinds of parameters, because we're seeing that primary and secondary level, right?
Yes, for sure. I mean, it's still, we don't want the app to get too complicated. So I'm not going to ask you, give me the age of every single person in the room and exactly what they're doing, because then it becomes kind of useless at some point.
Right.
It's too complicated. So here we just simply you can just hypothetically say, what if everyone's an adult? What if everyone's a child?
Got it.
And when it says speaking, what if everyone is speaking versus everyone is resting? For example, no masks and they're resting, or, of course, singing is on here too somewhere, and that's like the worst case scenario.
Right.
No masks and singing is like the worst. You notice, actually, yeah. So 7 minutes in this particular space for that situation.
Great, wonderful. Well, thank you very much, and thank you everybody for hanging with us for a little bit longer this week. This will be, as all of ours are going to be posted up on our website. So if you want to share it with your friends and family and crowd and principals and teachers, etc., as well as your senators and congressmen, that would be great. And we need to be advocating to get our kiddos back into school safely and our teachers to feel safe as well. So thank you very much.
Great. Well, thank you. And I'm sorry that I love taking questions and interacting with an audience. So I feel bad that we weren't able to do that today. If any of you would like to reach out to me, or actually Susan, if you'd like to schedule another, session of discussion,
absolutely,
I'm happy to do that.
Okay.
I'm very interested in outreach, especially for this issue of the schools. That's the topic that has really motivated me actually all along in doing this research.
Great. Yeah, are there any questions?
This is just Chris, and we just had a final question. What is the website? If one person asked, probably lots of people will ask. You can just Google Dr. Martin Bazant and COVID-19 indoor safety guidelines. You'll find it. But we will also send a follow-up email. There it is. Okay.
Sure, and and in fact, if you just even type in like Bazant, like you'll find me. My dad is possibly more famous than I am, so if you just type Bazant, you might get him first. But otherwise, if you type Martin Bazant, you'll get me, and on my homepage, it's one link to get to the COVID stuff.
Okay, perfect.
Great. Wonderful. Thank you all.
Okay,
Thank you, Martin.
Thanks, Dr. Bazant.
Thank you.
Bye-bye,
Talk with y'all
everybody.
soon. Take care.
Bye-bye.
See you next week. Bye-bye.